an anesthesiologist may be called upon to certify brain death. And therefore, due to all these reasons, it becomes very important for an anesthesiologist to understand what is happening with the brain dead patient and how to optimize and manage them. It is believed that anesthesiologists' guided physiological optimization of brain dead donors may be a factor in determining outcome of the recipients. With this thought in mind, let us proceed with the topic. I will be covering this under the following headings: intracranial events leading to brain death, physiological changes associated with brain death, because once we know the physiology, it becomes much easier to manage them for anesthesia, management of the brain dead donor, including declaration of brain death, resuscitation and maintenance of the organ donor, and intraoperative management during organ retrieval surgery. So let us first see what are the intracranial events which lead to brain death. It all starts with a neurological insult, either an acute intracranial hemorrhage or a head injury, which causes an increase in intracranial pressures. There is a progressive mass effect and the brain begins to herniate. As the brain herniates, it compresses the arterial components. This leads to ischemia and tissue infarction, which in turn contribute to all the physiological changes which happen with brain death. So what are these physiological changes associated with brain death? Before we go on to see the physiological effects, we need to understand this relationship. Mean arterial pressure minus ICP is equal to cerebral perfusion pressure. So from this, when ICP goes up, the body tries to compensate by increasing the mean arterial pressure and thereby trying to maintain the cerebral perfusion pressure to minimize the damage that is done due to the increase in intracranial pressure. So this is what we've seen so far: neurological insult leading to increased ICP, leading to herniation, compression of arterial blood supply, finally leading to ischemia and infarction. As the ICP continues to increase, ischemia propagates from the cerebrum to the spinal cord in a rostral caudal fashion. As we know, the brain